Good morning and welcome everyone to today's webinar, Best Practices in TeleSupervision. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenters at any time by typing your questions into the questions pane of that same control panel. I wanted to bring your attention to, we uploaded a resource list, and that is located under handouts under that control panel. It's a PDF, you can download that. I've also placed a link in the chat box that would direct you to the Transforming Chaplaincy website, and you can do the same thing. You can download the list from there. And with that, I'd like to introduce Reverend David Fleener, ACPE certified educator and founding manager of CPE at Stony Brook University Hospital in New York. David?
Thank you, Andrew, and welcome, friends and colleagues. I'm delighted that you have joined us for a very important presentation today about best practices in telesupervision. Before we get started, let me begin by thanking Transforming Chaplaincy for hosting today's event. I'd also like to thank the ACPE Foundation for their generous grant that supported research about online CPE during the pandemic, which was led by Chaba Sisgali, the incoming Executive Director of Transforming Chaplaincy. So thank you, Chaba. That research resulted in 2 peer-reviewed articles that we discussed in a previous webinar called Making CPE Accessible, Exploring the Pros and Cons of Online CPE. After sharing our findings about online CPE during the first webinar, we decided to invite an expert on telesupervision from outside our field to share what the broader literature can teach us about telesupervision. We're especially excited that today's presentation applies to both CPE educators and spiritually integrated psychotherapists. So without further ado, I'd like to introduce you to Dr. Arpana Inman. She's the Dean of the Graduate School of Applied and Professional Psychology at Rutgers University, New Brunswick, and a nationally recognized scholar in many areas, including telesupervision. She's widely published with over 100 publications and presentations in her name. Dr. Inman is a supervisor, trainer, and scholar, and recently co-hosted and developed the first DVD series on supervision models published by the American Psychological Association. She has presented at various conferences and conducts clinical supervision workshops nationally and internationally. She's a fellow of the American Psychological Association, a Fulbright Scholar, and a recipient of the Excellence in Supervision Research Award from the Society of Counseling Psychology section on supervision and training. Dr. Inman will present on best practices in telesupervision until the top of the hour, and then we'll take questions from you, our audience members. We've also invited 2 ACPE colleagues, Sarah Noel-Sweeney and Marcus McKinney, to help bridge the gaps between what Dr. Inman shares and how it applies to CPE and spiritually integrated psychotherapy. Sarah is an ACPE certified educator in the Memorial Hermann Health System in Houston, Texas. She's held several roles within the ACPE, but apropos of today's topic, it bears mentioning that she served as the founding convener of the Community of Practice for educators utilizing online options. Marcus, a licensed psychotherapist, is the director of the Academy for Community Health at Day Kimball Healthcare in Connecticut. He also serves as the director of the ACPE Spiritually Integrated Psychotherapy Training Program. Before turning it over to Dr. Inman, let me add that the ACPE Curriculum Committee will host a resource room about online CPE in the new year. So stay tuned for details about that. And finally, as Andrew mentioned, we prepared a resource list with all the resources I just mentioned, which you may find through the chat box or the handout section. And now, Dr. Inman, take it away.
Thank you so much. Let's see here. Good morning. I hope you can see my screen. Want to thank both ACPE and Transforming Chaplaincy for inviting me today to talk about telesupervision and how to bridge services in a digital era. Before I start talking a little bit about the area of supervision itself, I want to acknowledge that I work and live on the ancestral territories of the Lenape people, which is in New Jersey. And as indicated, I currently am at Rutgers University. What I'd like to ask of you actually is, as you start listening to this talk, perhaps in the chat, you can start posting where you are. And if you can kind of do a land acknowledgement of where you are situated. And if you don't know where to find the information, then you can go to this particular link that I have on the screen, https://nativeland.ca, and you should be able to find the ancestral territories or lands on which you're situated.
Dr. Inman, can you hold on 1 second? We're not seeing your screen, so I want to make sure that we get that rectified before we proceed.
All right, I'm sorry. Can you see that now?
Yes, now we see it. Thank you.
Great. Okay. So again, as I was saying, I'm on the ancestral territory lands of the Lenape people, and that's in New Jersey, where Rutgers University is situated. And here's the link for https://nativelands.ca, where you can find the land on which you are situated. So I encourage you to start posting in the chat just to let us know where you are. In that way, we kind of acknowledge where we are and what positionalities we locate ourselves in the context of the states that we're in. So with that, I want to talk a little bit about supervision. And I'm going to start off with talking a little bit about supervision in the context of what we all know about supervision. We know that clinical supervision is a core competency within the counseling field and really important in developing competent clinicians. There's enough research that shows that the role of a supervisor is important in terms of gatekeeping and really facilitating the skills and knowledge and processes that we engage in psychotherapy. More recently, with advancements in telecommunication, what we find is that there's a lot of more focus on computer-based technologies in supervision. And that's the focus of what we're going to be talking about today. I'm hoping that I can really address a lot of these learning objectives within the hour that we have, and hopefully can engage in a good conversation. So the objectives of this training this morning is really on identifying strengths and challenges in telesupervision, and looking at evaluating and implementing best practices in telesupervision. And I'm going to talk a little bit about the research and what the research says about best practices and what we end up then doing. And how do we incorporate ethical and cultural considerations in telesupervision? So I'd like to start off first with just seeing who is currently providing telesupervision. So if you go to this particular website and use the code, or you can use the QR code, and we can look to see who is engaged in telesupervision. So I'm going to end this shortly, and hopefully we can get the other link up. Okay, so we actually have a tremendous group of you who are currently providing telesupervision. That's fantastic. If we had been in person, I'd have asked you to share a little bit more about kind of what you've learned about telesupervision, but maybe we can go to that conversation later on as we continue with discussing these issues. So let me get back to the presentation at this time. So I want to talk a little bit about the historical perspectives and how we've kind of arrived to where we are today with telesupervision. So this is a really interesting snippet that I found, and this was in 1879. And I'm going to read the snippet to you. It's kind of um, very sweetly written. The Yankees are rapidly finding out the benefits of telephone. A newly made grandmama, we are told, was recently awakened by the bell at midnight and told by her inexperienced daughter, "Baby has the croup. What shall I do with it?" Grandmama replies she would call the family doctor and would be there in a minute. Grandmama woke the doctor, told him the terrible news. He in turn asked to put in telephonic communication with the anxious mama. "Lift the child to the telephone and let me hear it cough," he commands. The child is lifted and it coughs. "That's not croup," he declares, and declines to leave his house on such small matters. He advises grandmama also to stay in bed, and all anxiety is quietened. The trio settle down happily for the night. So what we see here is in 1879, we have people using the telephone for reasons of health. When we go further into the 1920s, what we find is that people are continuing to use the telephone as a way to engage in health, certainly. In 59 is when we have telepsychiatry being engaged in. And we find that the first instance of video conferencing occurs in 1959 at the University of Nebraska. So that's fairly early on that people are starting to actually use and bring it into the field of mental health. In the 60s and 70s, we have it come into counseling. And here you can see the mobile unit, which is starting to kind of be implemented. We have folks talking on a video conferencing, the old kind, and you also have NASA here that's starting to use some of these issues in counseling. In the 1990s and 1920s, there's significant advancement made in terms of telepsychology services. And what this is showing is that there's significant decrease in costs. And so people are starting to use psychological services at universities, prisons, the federal health system. In fact, in 2013, the Department of Veterans Affairs reported the successful completion of over 650,000 telepsychology sessions throughout the decade. And in 2013 alone, they had 200,000 sessions completed. That's quite significant. So we see that people are really starting to appreciate the access that this creates and to be able to use this service in kind of a broader, larger context and create greater access. In the 2020s, now this is with COVID hitting, we find that telemedicine, telehealth, etc., has created a greater visibility, has become extremely useful. And it also helps patients avoid stigma because they're getting treatment in the privacy of their homes. But you can see how it's increased over the years. So I want to share a little bit about some of the data that we find about the increase of virtual mental health demand. According to Rock Health, in the first half of the 2020s, digital behavioral health startups scored 588 million. That's really significant. According to Amwell, the largest telehealth operator, 62% of consumers preferred a virtual visit, even when it was safe for them to go to visit a doctor in the office. Before COVID, telepsychiatry was 80%, but after that, it jumped to 96% at the beginning of the pandemic. And 100% of those in psychiatry were willing to use telehealth post-2020. Ginger, which offers a text-based mental health coaching system for teletherapy and psychiatry, highlighted significantly how telehealth and mental health, telepsychiatry was increasing. Utilization rates were the highest in September of 2020. Mental health coaching increased to about 302%. Psychiatrists wrote 163 more prescriptions. And at the end of July, there was a 20% uptick in nighttime conversations with coaches, highlighting the stress and anxiety that was impacting sleep. So we can see how things have changed over the years, and certainly significantly in the last couple of years. Doctor on Demand, another telehealth provider, talked about teletherapy increasing over 50%. And most of the visits seem to have increased in terms of the kinds of populations that were using the services: men, those who used Medicaid, and patients over the age of 65. Big Health, another digital therapeutic company, highlighted anxiety levels surpassing the pandemic and the use of daylight products being used significantly. Teladoc reported a significant increase, certainly, but specifically for patients for over 65. Their visits increased by 16%. Men outpaced women in terms of access and usage. And specifically, men sought care for family reasons and relationship issues. That's an interesting shift, again, in terms of access, but also the safety in which people felt comfortable enough to access services. We know that people were using a lot of substances during COVID. So there was certainly a growing rate of alcohol and substance abuse for women. Generation Z account for 14% of the total mental health visits. They were facing significant anxiety. In fact, just this morning, I was watching the news and they were talking about how there's been a mental health, the health and brain decline for adolescents during COVID. This is very scary in terms of kind of what's happened during COVID and the need for increased access. I work at a university setting, and several of you are part of university settings, but also in just the community. Excuse me. What we find is there's more and more people needing access to treatment, and there's not as many mental health professionals available. There's big waiting lists. And so telehealth, telemental health is really key at this time. In fact, New Jersey, the governor recently just put out a call to offer telemental health services. There's a $10 million grant that's being provided for folks to be able to provide telemental health. So there's a lot of recognition of the need for mental health services and the role that telehealth and telemental health plays. And so in that context, certainly, it's important to think about what does this mean for supervision? Before we talk about telesupervision, I want to highlight some key phrases. The challenge that has been coming about in thinking a little bit about telesupervision is that there are multiple different kinds of terminologies being used. Telesupervision, cyber supervision, video conferencing, e-supervision, audiovisual supervision, distance education or learning, web-based supervision, technology-mediated supervision, teleconferencing, instant supervision, and clinical training through webcam. So you can see how challenging it could be for someone to go and look for literature to find out about best practices to say, how do we search? So it's important to kind of see how people are identifying or talking about telesupervision. As a psychologist, I'm going to be bringing in literature from the American Psychological Association, and I'm hoping that you can translate some of that to your own discipline. But telesupervision is really defined as supervision that's provided through electronic communication, whether in real time or otherwise through audio and video formats. And based on accreditation requirements, currently only 50% of supervision can be provided through telesupervision. The rest of it has to be in person. And I think part of this is the fields as kind of starting to figure out, is trying to kind of manage the tension of what we can do online and what we can do in person. So there's still a greater need for flexibility, but certainly COVID has provided a little bit more flexibility for the field of psychology, and certainly in other areas as well. One of the things that has happened with regard to telesupervision is that there are a lot of myths surrounding telesupervision. And so what I want to provide for you at this time is some facts about supervision. What we find is that there's very limited information on the quality and effectiveness of telesupervision. So just to kind of provide a little bit of a background in terms of why I engaged in this research, I was previously at Lehigh University and was teaching course in supervision. We had a year-long course, an apprenticeship in supervision for our doctoral students, and our doctoral students oftentimes provided supervision for our master's trainees. In 2000, we started developing an international school counseling program for our students who were overseas across the world in international schools. These international schools are typically run by and owned by and have curriculum that's based in the United States, Australia, and Britain. And so these students who are either counselors, principals, teachers were really keen on getting more training. And that's kind of how we started ending up developing a program in international school counseling. However, one of the things that was of concern for us is that when these students engaged in practicums or training, clinical training, we wanted to make sure that they received the kind of supervision we felt was important. And so I created a component in my course that allowed our doctoral students to provide telesupervision. There wasn't much happening at that time. There wasn't much literature in this area. But as I continued to do it, and certainly in 2020, when COVID hit, it became more vital locally as well. I ran a school-based mental health clinic while I was at Lehigh, and we had to pivot in 2020 when COVID hit, and had to train our doctoral students and our supervisees about telehealth and telesupervision. And that really made me think a little bit about looking at what is the literature saying about the effectiveness and quality. And there really wasn't much. And what we also found was that technology-based supervision occurs very frequently, has been increasing in frequency, but is rarely evaluated. And that's a problem. Certainly, even with face-to-face supervision, there's some literature in terms of how evaluation occurs, and there's some challenges with evaluation. Literature shows that supervisors struggle with evaluating their supervisees, especially when there's a personal relationship. It's hard for supervisors sometimes to hold supervisees accountable for fear of losing that trust and that relationship. This gets exaggerated certainly in telesupervision. However, what research also shows is that telesupervision has the potential to achieve the same benefits as face-to-face supervision if you set clear expectations and goals for telesupervision. We certainly have very clear expectations in face-to-face supervision. We talk about what the expectations are, what one can expect from the supervisor, the supervisee, what the evaluation process looks like, what kinds of things one can talk about in supervision, that supervision is not therapy. So we are fairly clear in those concepts and ways. However, with telesupervision, it becomes even more important. And the reason it becomes important is because of the fact that it's hard sometimes to assess nonverbal cues. And in telesupervision, we require a lot of intentionality. When we are there in person, we can see the body language. We can kind of get a better sense of the facial expressions, the way one might attend to things. However, in telesupervision, given that we can only see part of the body of a person, especially just the face sometimes, it's really hard to assess the nonverbal cues. And that's why it's really important in terms of thinking a little bit about intentionality, because what happens with assessing things on video is that we can easily assess things in a wrong way. But the other piece also, and I'm guilty of that, I'm assuming you are guilty of it as well, we tend to multitask. When I'm sitting in meetings, it's very easy for me to go and look up my email. It's very easy to text someone else and say something. Maybe you're doing it right now. But I think it's very easy for us to get distracted. And that's another reason why we really need to be intentional. We need to talk about what the expectations are. We need to be talking a little bit more about how we need to attend to each other in the context of the supervisory process. We know that one size doesn't fit everybody. That's true of any kind of a situation. However, what's really important is that we as supervisors and supervisees are competent in the technologies that we use. That is really key to successful supervision in a telecommunication process or setting. And what the research shows is that when especially supervisors use technology effectively, it leads to positive supervision outcomes. And what's most important also is to anticipate and manage the technical problems that might exist or come about proactively. And I'll talk a little bit more about this in terms of what that means. What's the other interesting research that we find is that it's important to complement telesupervision with face-to-face supervision. And what the research shows is that when there has been some level of face-to-face supervision, supervisees oftentimes are more satisfied when they meet online. So it's interesting because one of the things we looked at in my class is that we had doctoral students who provided face-to-face supervision for our local students here, and they provided online supervision for students internationally. It took them a longer time to develop a relationship. They had more challenges in that supervisory relationship when it was only online than when they had it in person. Now, that's certainly anecdotal, but the research seemed to support that. So that's something for you to think about as you engage in telesupervision. Is it possible for you also then to have some kind of face-to-face contact in another setting? Maybe, and again, it certainly depends on location, but certainly if you're able to connect with the people at a conference or do some other kind of networking, meet for coffee. And what's important also in the telesupervision process is that continuity and availability is more important than the location. It's really, and we all know that supervision, consistency in supervision, continuity in supervision, availability of the supervisor for the supervisee is very important to know that as a supervisee, I can access my supervisor when I need them. Has certainly been important for me as I was a trainee and also in clinical work. But beyond that, in telesupervision, given the technology aspects, we really need to be focused on security and safety and confidentiality. It becomes even greater in the context of telesupervision. So, in summary, what we kind of know about telesupervision is that telesupervision and in-person supervision are equitable. In a sense, good supervision is good supervision no matter how you do it. However, with telesupervision, you do need to adapt your supervision skills, and technology plays a really key and important role. It's kind of similar to kind of what happened at the start of this session, of this training, where David mentioned that you couldn't see my first slide, and I thought you could see it. So again, communication, discussions, conversations about kind of expectations and quick feedback is really important in this process. So what do we need to consider when we think about telesupervision? It's essentially the same requirements as an in-person supervision, but it's a bit more, just a little bit more. So I want to start off talking a little bit about benefits and challenges, and I'd love to hear a little bit later on to see whether you've experienced these benefits and challenges and what you've learned from your experience in telesupervision. So what we know is that telesupervision creates greater access. It's reduced costs. It doesn't involve us to travel. So that's kind of great. We can do it from the confines of our office, our homes, wherever we may be. It creates a lot of flexibility, which is important, right, in today's day. It also allows us to share digital files very easily. And so that's kind of an important piece. Certainly security and confidentiality is important. What's also interesting is you get to see the human side of people. And what I mean by that is you can actually see right now the background of my office. You can see some of the personal items that I have in here. It's kind of different, and it's in my home, right? Compared to in an office setting where we don't always bring a lot of our human side sometimes into the setting. So it's kind of an interesting piece. Sometimes cats walk across our computers, right? So people have experienced some of those pieces as well. So there's a human side, an element to it. It allows us to increase our interactions with diverse communities just because we are able to create greater access far and wide. It reduces wait time, and we can talk I'll talk a little bit about that in a bit. It reduces unfamiliar environments and the stress of it. And this is particularly true for clients where if there's such stigma related to mental health issues, it's easier to do so from their own homes in the way they want to engage with you. And there's some benefit with regard to the notion that it improves rural healthcare. With regard to challenges, certainly confidentiality is a big issue. People can walk in and out of the space when you're working with people. And if you don't speak a little bit about kind of how to maintain that office and be in a professional setting, it's really important to think a little bit about what that means in terms of confidentiality and where supervision occurs. Technology and what's your speed of internet, access to internet. Certainly those are, and how comfortable you are with the different formats. Navigating the ethical codes and laws across states. In terms of rural areas, mountains, etc., can create some challenges. There's also isolation that happens in rural areas, so that can certainly be a challenge. Lack of personal contact, if you're only engaging in telesupervision, is something that we need to think about. But it also requires a lot of self-directed learning on one's part when we engage in this process. And sometimes immediate feedback may be challenged. Again, it depends on how you kind of set things up. What the research has shown is that there have been significant barriers for clinicians and supervisors in these different areas. Reimbursement, how do you get reimbursed? What kinds of processes do we set up for that? Regulatory, licensure, working across states. As I already said, there's not clear evidence in terms of telehealth and telesupervision. It's growing slowly. Certainly people have identified best practices, but what we find is that people do kind of a hodgepodge of things. They don't really engage in the best practices in the way one should. And again, part of this is people are still figuring things out. Adopting technology and the use of technology and the kinds of technology that are accessible have also created some barriers in the larger scheme of things. I thought this was an interesting clip in terms of thinking a little bit about best practices. These are some basic things, tips on making a presentation on a video conference or webcast. You check all systems, avoid eating, put your pants on, right? We've all been there where we worn our bunny slippers sometimes when we've engaged in work over the internet. So again, how do we present ourselves in a professional way? How do we educate and create expectations for our clinicians, for our clients, to still use the space in a professional way? So I want to talk a little bit about just the basics in technology, and several of you, about 70% of you said you've been using telesupervision, telehealth technology as a way to create access and provide the services. So some of this may be familiar to you, but I just kind of feel it's important for us to kind of have the basics and the foundations of what it requires in terms of providing telesupervision. Certainly having a reliable computer, a good webcam, making sure that your microphone works well. Camera angle background is very important. I've had times have been settings where I feel that I might be with someone in a protection plan, where everything is kind of dark or the face is dark. And so it's really important for you to kind of talk a little bit about how to set up this office space. I know right now, I think there's a little halo around the back of my head. So, it's really important to kind of be aware of your surroundings and also to talk about how to set things up. Your facial expression, certainly, because we have a hard time assessing the cues. The tone of voice, hand gestures, how you dress are all things that I think sometimes we take for granted, but I think we need to be more explicit in discussions when we think about what we want in that relationship. What has been identified as reliable internet access is about 3 Mbps downloads and 1 Mbps upload. And you can check your speed at this particular link. And I believe that these slides will be shared with you later. And so you will have access to some of the links that I've put on this in this PowerPoint. There's certainly all platforms need to be HIPAA compliant. So it's really important to make sure that your platform that you're using is HIPAA compliant. Please know that those platforms that are not compliant are Skype, Google Hangout, and FaceTime. Please do not use those in the context of your therapeutic work and the supervision work. Make sure that whatever health provider and technology company you're using has a business associate agreement, and that suggests HIPAA compliance. There's several platforms that are available right now. I'm not promoting any of these necessarily, but I want to highlight them. There's TheraPlatform, OHMD, Zoom for Healthcare, Doximity, VC, Doxime, Medicity, TheraNest, and TheraLink. There are plenty of these platforms. All of them are HIPAA compliant. One interesting thing about the TheraPlatform is that it allows, if you're in a training setting, it allows the client and the student to be in the therapy session and invite the supervisor into that session, with the supervisor who's observing being invisible. So this means that the supervisor can hear and watch the student, therapist, and client interacting, but the therapist and the client cannot see the supervisor. So that's kind of an interesting feature if you ever decide you want to use it. Again, I'm not advocating for any of these necessarily, but these are what's available out in the community. And the other one that I want to highlight, and maybe some of you are aware of this, is the motivohealth.com website. This is a place for you to sign up if you are interested in providing telesupervision to people in the community or anywhere. I have a good friend and colleague who signed up for it and is very happy with that service. So certainly consider thinking a little bit about whether you'd like to be part of that network. The other things that we need to think about as we think about use of technology or doing telemental health or telesupervision in particular is expectations and communications. How am I going to communicate with my supervisee? Is it by phone and by text, by email, by video conferencing? When can we use the text function? When can we use the email function? When would we be using the conferencing function? Being very mindful also of surroundings. I've known of supervisees sometimes engaging in supervision when they're driving to a store or when they're driving. We know it's dangerous to do certain things while driving. Certainly confidentiality is an issue if you're engaging in discussing client work when you're shopping. Certainly the lighting, the noise, silence notifications. I did that before we started this training today. I turned off all my email, and certainly privacy. So those are some things. Again, I know what I'm sharing right now is something that you all know, but it's really important to make things explicit. And certainly flexibility. Flexibility is really key in all that we do. And the reason why people have really appreciated access to TeleSupervision or technology is the fact that it creates some flexibility for us. So what we find is that when we think about successful telesupervision, a lot of the factors are very similar to what we see in terms of in-person supervision. Certainly supervisor-supervisee characteristics, the supervision process itself, how do we communicate? But when we think about telesupervision, certainly technology is a factor. The environment in which we do telesupervision is important. Having prior in-person contact and certainly relationship. There's significant literature in the field of supervision with regard to the role of the supervisory relationship, which helps build trust, create a bond, create safety. And what's been found is that when a supervisor is very proactive in addressing technical issues or expectations, provides immediate feedback, is able to read nonverbal cues, supervision tends to be more successful. With regard to the supervisor themselves, it's important certainly to be flexible, willing, and have the experience and comfort with technology and certainly supervision. With trainees, flexibility and willingness is important, but also considering the developmental level. So you need to consider what kind of scaffolding and oversight do you need to provide for your supervisee as they engage in this process. And certainly the logistics are important with regard to technology, space, access to supervision support, and I'll talk about that in a minute. Comfort with technology. And I know I'm not really sharing things with you that you may not be aware of, but within the context of telesupervision, it becomes even more important to be explicit. So for the supervisor, it's really important to have technology self-efficacy. I know I worked a lot on that with my trainees when they were engaged in telesupervision with their supervisees. We had an IT person who was available to be able to support the students internationally, but also the students here, especially given that my students were providing supervision across different time zones. Just like regular supervision, we really need to be able to talk about who's the primary supervisor, who's the backup supervisor. What kind of oversight are you going to be providing? Is it regular supervision that's scheduled on a timely basis? How do you do on-spot supervision? How do you do ad hoc supervision? How do you use technology in that context? Do you use texts? Do you use email? So again, all those pieces need to be discussed. Building a relationship has to be very intentional, especially given that we're not there in person. So timely, meaningful, intentional feedback is very important. And research for in-person supervision highlights this as being very salient. So it becomes even more important when we think about telesupervision. And certainly privacy of records and contracts. With regard to the supervisee, we need to assess the baseline in terms of their comfort with technology and the platforms that are being used. Talking about, do you want instant messaging? When should a supervisee contact you? What is considered an urgent and emergent issue? So really being explicit in terms of the expectations for check-in. And again, training our supervisees to consider that for our clients as well, in terms of recording expectations, explicit communication about consent, confidentiality, especially in terms of adolescents, young adults, especially if you're doing something within the home. And when do you schedule clients? I know with technology, there's a lot of flexibility, but how do you kind of still maintain boundaries with regard to your time? Because people are talking a lot about burnout, Zoom burnout, especially in this age of technology. When we think about telesupervision in a rural setting, we really need to be mindful about the kind of technology we're using, and video conferencing is certainly better than phone. Again, we want to have as much face-to-face contact as possible. Just as we might engage in discussing cases and looking at charts, etc., you can certainly do that in a in the context of technology as well, doing chart audits, patient sessions within telesupervision. It's really important to prioritize your time for supervision. And again, this kind of relates also to the organization in terms of how supportive your organization is, especially if you're working in the context of an organization, in terms of the time that they allocate for supervision. If you're engaging in some kind of training, certainly with Zoom, we can have breakout sessions, breakout rooms. So it's kind of technology has provided us some mechanisms of actually being able to engage in training as well. Professional development is certainly important, and you're doing some of that right now. And considering audits to ensure that the supervision is following processes, policies, and guidelines. And again, if it's within the context of your organization, making sure that your organization has some clear policies in regard to telesupervision and not just face-to-face supervision. And that kind of brings me to the cultural and ethical considerations. And we do need to consider what are some cultural considerations in regards to telesupervision. What are some risks in practicing across state lines? And what are your state laws about telesupervision? And most states have different laws and expectations that I'll touch upon a little bit, but I'll also give you some resources that you can access in the event that it's not easily accessible. There's a lot of talk about multicultural competence in the field of mental health, in the field of supervision. And multicultural competence really refers to awareness, knowledge, and skills, right? But people have kind of moved away from that and said we need to move away from that to looking at the notion of cultural humility, which is really a core foundational factor where you're able to highlight and acknowledge the limitations you have, to be able to go beyond just the knowledge and awareness, but to also recognize that we don't know everything. And that cultural factors do influence communication, understanding, and the humility or the understanding underlying some of those pieces are really important. All of us have biases, and we really need to be aware of those implicit biases, not only in terms of how we engage, but also the language that we might use, and that it should be inclusive, respectful language, and especially in the context of technology literacy. How do we understand health and well-being in that context? When I was working at the when I was directing the school-based mental health clinic, one of the things we are doing, because we had a huge Hispanic community, is we would use language assistance. We would have a system where people could call in and translate. It was great to have that access, but it also wasn't always conducive to the relationship because we had this other person kind of translating. So what does that mean in terms of how do you engage in that process and build the relationship given these extenuating circumstances? According to APA, psychologists make reasonable efforts to be familiar with and address the laws and regulations that govern telepsychology within the jurisdiction in which they're situated and in which the patients and clients are located. And I know that these kinds of guidelines cut across multiple behavioral health ethical guidelines. What's important in regard to all of this is attention to technology, intra and interagency policies, and the legal requirements. So what we know is that there are guidelines from the American Counseling Association. There's guidelines certainly from APA, American Psychological Association. There are very specific guidelines that APA has put forth in terms of competency-based clinical supervision. AMFT has guidelines, NBCC has put forth guidelines, you folks have guidelines, the Common Code of Ethics for chaplains, pastoral counselors, etc. And the other thing that I wasn't aware of that I came across as I was doing this training elsewhere is the American Distance Counseling Association that was established to create a network for counselors practicing telesupervision. In all of this, what I find is that there's certainly a lot of guidelines related to therapy, psychotherapy. There's perhaps maybe one paragraph on telesupervision. And recently, as I was actually giving some feedback to APA on the guidelines for telepsychology, I talked about the need to really expand the focus on telesupervision. We don't pay as much attention to that in the guidelines as we should. So I'd encourage you to go back to your own guidelines and advocate for and maybe work with your organization to develop stronger guidelines based on research, based on your practice, so that you are able to get the guidance that you need. So one of the key considerations when we think about telesupervision is certainly access and equity. There's clear guidelines that, again, I've put out here that are available to you. But the other piece also is kind of getting familiar with your organization and state regulations regarding e-supervision. If you're working at a university setting, what are their policies for implementing video conferencing platforms or any additional software or technology? Review the budget that your university has to support technology and investments in technology. Reach out to your potential stakeholders, whether it's in the university setting or otherwise. Evaluate your own current technology in terms of the age of your computer, the internet connection speed, network capabilities. Research different video conferencing platforms and the technical requirements and see, what fits. And oftentimes you might be able to sign up for a free trial. So you should certainly look at, accessing some of that when you think about just your organization. But you also want to look at your state and federal regulations, and you can locate those at the link that I have up there. You can look at your licensing in terms of your own jurisdictions. We also have what is called a psych pact or compacts, where essentially there's a relationship that's developed between several states, so you can practice across states. Here's what we have for a psych pact in terms of access. So someone in Pennsylvania could certainly work with someone in New Hampshire or Arizona. And then we have the e-passport certificate that facilitates psychologists to practice across state lines without obtaining additional licenses. You may want to look at what access you have for your own profession to see if you're able to practice across, if there's something like an e-passport that'll allow you to practice across state lines. The other thing, especially in rural areas, and some of you might be in rural areas, I really couldn't find much information about what's happening in rural areas with regard to telesupervision. But what we find in Kansas, for instance, is that they've removed in-person supervision requirements to obtain licensure. So about 2/3 of your supervision can be done electronically. In Oklahoma, only 56.25 hours account for telesupervision of 3,000 hours of required experience. So there's a lot of variation in terms of what each state is allowing people to do. And what they do when they're considering telesupervision, or when they allow telesupervision, is they look at the distance between the approved supervisor and the candidate, the financial hardship on approved supervisor or candidate, physical hardship on approved supervisor or candidate, the specialty credentials, and some other factors. So the number of factors that are taken into consideration to kind of designate and identify and allow the telesupervision. For you to find out a little bit more about telesupervision or telecollaboration in your state, you can contact the HTRC, which is the Heartland Telehealth Resource Center. So you can contact them at that phone number. So with that, I just have a few references here for you. Again, happy to share the slides with you with regard to all of the information and the links so that you have access to them. And at this time, I will end my presentation and open it up for any questions or comments.
Thank you, Dr. Inman. I really appreciate your presentation. So much good information there. And we do welcome you to place your questions in the question box, and I'll be reading those and pitching those to Dr. Inman and also Sarah and Marcus. And Marcus, if you can turn your camera back on and join us, we can begin our Q&A session. And also, Dr. Inman, if you'd be able to unshare your screen, we can see each other better. So we do have one question in the chat box, and I'll read this and make it available to any of the three of you who want to respond. Marianne Brody writes, I work in a freestanding center and my students are in a variety of healthcare settings. I believe Marianne is a CPE educator. She says, I like to see, in quotes, my students working, and I often run into difficulty getting access to my students actually working unless I come in physically. What have others done about this? So as I understand the question, many of us like to observe our students in real time in clinical pastoral supervision, and I'm sure that's a part of psychotherapy and psychological supervision as well. So how do you overcome that distance?
Maybe I could start by saying the first thing that came to my mind is in clinical practice where I serve, I happen to be in a hospital clinic. Whether it's supervision or individual therapy, I'm very cognizant that we need to have one initial visit with the person at least, in person. Sometimes that's not possible for a whole bunch of reasons. But I do think that's the ideal, and we reach as hard as we can to get that. Some person-to-person encounter, and then from there can be a distance of meetings that happen that do not require person-to-person, but it's hard for me at this point, particularly since our practice in the hospital requires us to have that initial visit in person with a client. It's hard for me not to get over the need I now have to see a person on occasion in person. So we set our own boundaries when we start the contract with a supervisee or a client with that in mind.
Thank you, Marcus.
I can also add just a little bit. Marianne, I know you're out there. Hi, Marianne and I've had a lot of overlap over the years and in terms of distance and supervision. And I don't have solutions, but I have some things that I have done as I've supervised students from across the country and in other countries, which is to develop really strong coaching relationships. So in CPE, we have like the idea of the clinical coach or the clinical mentor in addition to the educator or primary supervisor. And in most healthcare settings I was in before I was supervising much over distances, that was a lot me doing kind of both of those things. And there might be a coach sort of in addition in the wings, but that triangle became a lot more solid and a lot more important when I was separated by geographical distance. So my relationship with the clinical coach, who did have the ability to shadow them and be shadowed by them in person, became more critical to our relationship. So I had to be in good communication with the coach more than I had ever had to be before, and with the student with the coach. So that that triangle had to be really solid. And I had to let go of a lot of needs that I had had and a lot of what I had felt were best practices in the past. So being back in now a healthcare setting and not doing distance supervision, being able to shadow my students and have them shadow me with more ease has been a relief. But I'm glad for those years that I did cultivate my ability to lean onto the clinical coach to do some of that, fill in some of that gap.
And Sarah, following up on that, did you meet with the clinical coach and the CPE student together? And if so, what was the regularity and how was that, given that our training is mostly the one-to-one interactions and individual supervision with our students?
Yeah, so I think that was a big benefit in terms of my own learning as an educator, was to gather the coaches together with each other as coaches at the beginning, the middle, and the end of a unit of clinical pastoral education, so that they were learning from each other, like how to be a good coach. But then also me meeting with the coach, usually 2 times in the first half and 2 times in the second half of the unit. And then it was a little bit more as needed in terms of student, coach, and me meeting together. So there was some regularity, but it wasn't like set times necessarily. I have found that since I was doing that, I have brought that into my practice now that I'm back in sharing a hallway with all of those same people. So I'm much more intentional in the relationships I have with my students' clinical coaches than I was before this happened.
That's an example of another one of those developments from the online space that works well and may in fact improve the in-person space.
It certainly did mine.
Dr. Inman, did you want to weigh in on any of that from your perspective?
So I'm kind of curious about the clinical coach. I'm not aware of that process, so that's kind of an interesting piece that I'm hearing in your discipline. But I think one of the things, certainly, it's a matter of kind of being a little bit more creative with regard to how we create access and how we're able to observe. I know when we were providing supervision for our international students, they would record their sessions and they would send us the video clips that we could then observe and provide the feedback. So, and I know at least in the United States, there are a lot of accrediting bodies that are requiring us to be there in person and observe, because they're also, because of confidentiality reasons, they're actually not allowing videotapes to leave a training setting. So it creates a bit of a challenge. So I think it's an interesting dilemma in terms of how to really create that process. So having the clinical coach is a great way to kind of address the issue.
And there's a follow-up question, Sarah, on this topic, and that is, how did you train them? Did you have behavioral descriptors that you used in training coaches or preceptors, mentors, whatever we want to call them?
Yes, so I used the ACPE outcomes and the behaviors that I had generated for the particular center that I was working with. And I, especially the pastoral competence section of the ACPE outcomes, I utilized those behaviors and just gave that list over to the coach and said, I'm looking for the student to be able to demonstrate these behaviors in the beginning, kind of middle and end of a unit of CPE, depending if it was their first, second, third, or fourth unit. And so the coach knew in advance, in the middle of the unit, this is what I'm going to be asking to see if you've observed.
Excellent. Sounds like a great resource. Not to add any more work to anybody, but I'm sure there will be a number of ideas today generated where we'll say, man, if there was only available somewhere where I could take a look at it. So a couple of other comments and questions. Tom Backer says that he makes site visits, and I think that makes a lot of sense when you're in the location. Obviously, one of the most obvious benefits of telesupervision is the accessibility, and that we can train people all over the world. I'm working with a group of online students, and we're all in the New York area, so we can meet and I can go see them as needed, but that's not always the case. And so there's a follow-up question here about that. Dr. Inman mentioned technology where a supervisor can watch an online session without being visible to the supervisee. Wonder if that would help in this question. So I think maybe we could talk about that from both perspectives, the counseling perspective, where there's more of a contained opportunity for that, and then the healthcare clinical pastoral supervision perspective, where it's more challenging. So Marcus, we haven't heard from you in a minute. What do you think? Do you have experience with watching online sessions of your supervising?
I think as we use that, it works very well. The technology is a bit of a concern. On my side is a little easier because I'm in a hospital, although I've got to admit, I have students now that I work with from Zimbabwe, and the truth is their technology seems to work much better than Connecticut, so that's another whole thing. But it is a consideration about mutual technology efficiency, but then, you know, permissions and things of that nature. But we do it some over the last 2 years, somewhat out of necessity, and it has gone very well and been received well to observe without being seen. Everybody knows it's going on. The client knows, everybody knows and consents to it, but it's been very effective for a more real atmosphere to be taking place for the supervisee to be doing their work. There's also another component that I know Dr. Amnon is aware of, but I always have to keep in mind the requirements and extensive manuals of the schools that are sometimes involved in the equation. So I've got people coming from schools, then they have their locality, then they have my hospital, then we have the professional. I mean, it's a trick to make sure all are met, but to the point, it's been very effective so far for us to have that kind of observation.
Great. Dr. Inman, do you want to build on that since we're talking more about the counseling space?
Yeah, I have not used that platform, so I'd certainly welcome folks to check it out. Again, I'm not advocating for anything, but you know, there are all these different platforms, and I found that very interesting. But as this question came up, it made me think a little bit, slightly off the topic here, but I recently moved. And when I moved, I had movers come and they had a software where I was moving from Pennsylvania to Ohio. They sent me a link and I could walk through my house and show them the furniture, all of the different things that I had never encountered something like this. And I'm kind of wondering, why not bring some of that technology into counseling, where if you're interested in seeing the location of where the supervisee is, you know, they can walk you through the clinic, they can show you the space, they can show you their office. It's just a thought that came to my mind. We should talk to the moving companies to find out where this software is and how to access it. But I'm thinking also of the one-way mirrors. I know in the olden days, or even some clinics now, and I know we have that at Rutgers, where we have a one-way process of kind of watching what's happening in the session. And the supervisor and the supervisee and the client, supervisee and the client know there's a supervisor sitting behind that one-way mirror. And I know in the olden days, especially in marriage and family therapy, there would be a call in to kind of say, here's what you need to do, or stop what you're doing and change it. So I'm kind of wondering if we can use some of those like bug in the ear kind of a mechanism that used to be used. I don't know how much it's used now, but is that another way for us to kind of engage in that process?
Interesting. Sarah, how about from the CPE and healthcare perspective?
Yeah, I'm thinking about kind of two layers in our work. One is when we are training a new educator, and certainly all of that I think our organization has done a really good job regulating and encouraging how we record all of that happening. So if we have someone who's becoming an educator and they're working with students, that work's being recorded and reviewed. So that makes that a little easier to supervise from a distance, although that relationship has been more difficult to justify in our organization to do from a distance. But I'm thinking the other and perhaps like more pervasive avenue for this is when our student chaplains are working with patients in the healthcare setting, in which case every environment I've been a part of, there's no possible way to pipe in an educator from a distance for that you can't record anything that happens with the patient for use in any other way in the environments that I've been a part of. So David, I don't know if you have anything to add differently from that, but that's been my experience.
Yeah, I mean, two things come to mind. I agree with your experience. That's been my experience as well. I'm curious what other healthcare education programs do if they already have models that we could adapt or borrow. And in the kind of the strange and weird category, a couple of years ago at a healthcare system I worked at, we had a documentary filmmaker who approached us and has made a documentary about CPE, and he was able for 9 months to get permission from patients to film encounters with chaplain CPE residents and interns. And so that really showed me that hard and fast wall or rule that we imagine is permeable in some ways. And there was hospital approvals and ethical considerations. Everything was taken into consideration, and patients were willing to have that happen. So, it seems possible. It seems possible. And by the way, that documentary just got accepted to the Sundance Film Festival. So that's going to be debuting there. So more to come about that later. But let's move on to another question. We've got some interesting questions here. So one of the things that you brought up, Dr. Inman, is licensure and regulations, especially across state lines. So the question is, how does the fact that the lack of licensure on the part of CPE educators affect our telesupervision practices? Are we at risk for liabilities that we're not aware of? So just to let you know, Dr. Inman, those of us who are not psychotherapists, those of us who are CPE educators, are certified but not licensed. The state or federal government really doesn't regulate us. However, I have been advised, I think our association does advise us, those of us engaging in telesupervision to buy professional liability insurance. So I'm curious what you know about that and what you could say.
Wow, I'd have to think a little bit about this. I'm trying to kind of think a little. So if it's similar to kind of an educational process where you're doing some training, where it's a consulting relationship, I think there's some leeway in terms of those processes. Certainly you have liability, and I'm glad that you're getting the insurance for that. But depending on the relationship and depending on how you identify the relationship of whether it's an ongoing relationship or it's that of a consultant, there's certainly a little bit more flexibility in that process if you are as a consultant.
David, can I throw in one thought here? Well, maybe two quick thoughts. One is I've always felt, for many years, I have felt, being primarily in a healthcare institution, increased access to care is going to be the big challenge and requirement. We're going to have to find creative ways to access more care for more people, whether it's mental health, spiritual care, anything like that. Now, with that comes all these problems, liability questions. What's the difference between the word care and psychotherapist and pastoral counselor? All these things are now the mess that is an opportunity. But if we're going to access more care for people around the globe, not just in this country, I think those things are why this kind of a meeting we're having now is so important. However, I do think that is done individually with people who are listening. There are some people, and this is my second quick point here, people may not know this, but in ACPE now, under the psychotherapy section, there is something called the spiritually integrated psychotherapy training, and people getting identified with that work. These are mostly at this point psychotherapists getting spiritual training, with spiritual perspectives and theory and practice. But then there's also the pastoral care specialist. So in that way, the CPE challenges of being identified in a certain way, of taking some risk to do psychological work, but they're not psychologists. They're being therapeutic, but they're not therapists. This is the great opportunity. And I reference people to Thomas More, who I've worked with for years. His latest book is about therapy, and blanking on the title of it. But Thomas More and therapy, it's really around being therapeutic and not being a therapist. But when we do that, it invites all the things we're talking about now, and that's the future for us to work out, so that we keep people safe, both clients or people we're caring for. But it also raises the significance of the word care, as opposed to only therapy. And I think that's I'm excited about that myself. More access to care.
Yeah, Dr. Inman.
Can I ask a question based on what Marcus said just now? That thank you for that information. And I'm wondering if all of the folks that you're talking about oftentimes work in the context of an organization, because if it's within a hospital setting or if it's within a particular organization, then the liability can be covered through the organization.
Right.
So I'm kind of wondering if people are doing private practice, or are they within the context of an organization?
So if we're just talking about not psychotherapists, but care providers, what I call care providers, they're not posing as, they're not speaking like therapists, they're not diagnosing or treating in that way. Then we're talking about people who are most often affiliated with some faith-oriented group, whether it's an official denomination, an individual church that authorizes them to do this, or a nonprofit that's identified with a board and authority. In many states, but not all, my experience, and certainly in Connecticut, would be that the exclusion to allow you to be able to do counseling, but not get in trouble with the law, is that you are not performing the responsibilities of what a licensed professional counselor would do. Now, what in the world is that? Well, it includes diagnosis and treatment. I can't see somebody as a therapist and not diagnose them. So there are some clear things that everybody needs help with who are doing care work. And the reality is, David and Dr. Inman, that people are doing this anyway in their little congregations. And what I think ACPE has done to this point is say, we need to have our eyes open and help these folks not get in trouble, but honor the role that they are called to perform. But there's a lot more here, Dr. Inman, that I don't have answers for, but I'm excited about, because the communities, this is all community stuff. This is less institutional and more into the community, so it raises challenges but opportunities, in my view.
And if I might just add, it's interesting you talk about that, because when I was directing the school-based mental health clinic, we did go into a church because one of the ministers there wanted us to do some parenting skills workshops. And so we were trying to really create access where it was needed, rather than them having to come into a kind of a scheduled therapeutic setting.
Yeah.
Allowed us to do something a lot more different. Certainly these were trainees and they were working under my licensure, but I think it highlights a little bit more about kind of the community access and focus.
Absolutely.
Well, on the topic of regulation, I've been interested in how the ACPE would or would not regulate online or telesupervision over the last decade as it's emerged. And the regulations are very thin at this point, which I think is a good thing, because there's a lot that we don't know. I was really interested to learn about, I believe, Dr. Inman, it was the APA requirement that only 50% of supervision could be done remotely. And I wondered what you think about that.
So this is something we are kind of dealing with right now in our clinics at Rutgers. So it's really creating a challenge for us, because we don't have enough supervisors. And given kind of the pivot that we all did, and people becoming more comfortable with really providing services online, a lot of folks are really saying, if I'm going to come and work with you, I want to be able to do it online from my office, my home. So I'm hoping that that's going to be a conversation within all of these different associations and looking at guidelines and what it means for accreditation. So it's a kind of a critical time right now for us to be thinking about how we want to be engaging and providing and getting access to excellent supervisors. Yeah, I think the field is kind of struggling right now in terms of what we need to be doing. So while on one hand I recognize, and I think that's been part of the conversation here as well, that it's important to have that face-to-face interaction, but we also need to think about access.
Yeah, and Sarah, what do you? I imagine you've thought about this quite a bit, given your experience. What do you think about regulation from the ACPE or wherever?
I think too many things to say, but let me see if I can say something short. I think that the more research we do and the more interaction we do interdisciplinarily like this, the more likely we are to come up with the guidelines that work for our particular profession. I'm wary of arbitrary guidelines that we might put on ourselves just so that we can say we're doing something, so we're not all Lone Rangering it out there. And I'll stop.
I am 100% with you. I'm worried about arbitrary guidelines. You said it so well, because what we're doing is we're working at the edge of the access, which is such a benefit. And the other side of that is wanting to make sure that we protect people in our care and provide quality supervision. And we just don't have enough information. Do you think that's fair to say, Dr. Inman? That's what I got from your presentation. We don't have enough information or research at this point to be very definitive about it.
Yeah, and I think, what Sarah just said, the word arbitrary made me think about reactive. We tend to be reactive rather than proactive. And we need to be more intentional as we move forward.
I think particularly in ACPE regarding chaplaincy, we have been reactive because of other organizations that have sprung up with less requirements than ours. And I think sometimes the urge for more requirement has come as a way of saying we're not them. And I think that could be and has been a mistake in the past.
Highlight a couple of a theme that came up in the questions that goes back to the larger issue of when you're off-site. People are mentioning sim centers, simulated patients, working with patient actors, and often in healthcare. I've done that with medical students. One of the barriers is the cost of it. Even when I've been inside institutions with sim labs, departments still had to pay, and CPE budgets are not very robust typically to be able to do that. Dr. Inman, do you have any experience with using sim labs?
Yeah, I had explored this company called Munson, I think, that had those kinds of processes available. It was mainly for teaching initially, and then they moved it into counseling, where you could have this person kind of respond in AI process. I don't know too much about it, and I'm wondering, I'm sure it has some merit. I've also been reading a little bit about some of these other online services that are being provided right now in the nation, Better Health, other kinds of things, where I believe sometimes they're creating avatars or providing certain kinds of access and help that's really not relevant, that the AI is not functioning in the way it should. So I'm a little nervous about some of those pieces. On the other hand, when we talk about role playing, I'm thinking if you're in university settings or even community where they're actors, I wonder if you can bring actors coming in and playing out a role where then students can have access to someone. It's like, I don't know if you watched the show Seinfeld, where Kramer took on a persona that the medical resident could then evaluate and kind of say, here's the diagnosis. It's a unharmful way for students to learn. So I'm wondering if we can actually connect with local theater, community theater, or even in universities with the arts, the theater department to kind of help with some of this.
Yeah, and I've worked with that before in the medical school at another institution I worked at, and it's resource intensive, and among actors there are that's its own specialization, becoming a simulated patient or a patient actor. So you know, if we had more resources, that might be a good possibility. And I'm interested in the AI. You know, obviously Mark Zuckerberg has gone all in on the metaverse, and I don't know if anybody's familiar with Second Life, which is kind of the metaverse 1.0, but there is some conversation I've heard about using that kind of technology for training opportunities. You know, who knows? Maybe in 10 years we'll be talking about that more on a webinar. We've only got a few minutes left. I want to offer another question or two before we end. From Elenite Goldberg, I'm interested in your thoughts on the relative benefit of supervision in person while wearing masks versus telesupervision, where you can see each other's facial expressions, but not as much body language. I taught CPE via Zoom for 2 years, and I'm now teaching mostly in person, and I've been thinking about this a lot. What do you think is preferable in a context where masks are required in person? I think that's
I can go first, but unless somebody else wants to start.
Go ahead.
Go for it.
I was just gonna say, I wanted to underline and echo what you said, Arpana, about the combination. For me, when we were going in and out of the hospital, constantly shifting requirements about what we were allowed to do and not do. Could we be in a room as 2 people without masks, or did we need to have masks? Sometimes from week to week, those things changed over the past couple of years. And so I really found what you said to be true in terms of meeting with students on Zoom, meeting with students in person with masks. That combination helped me to get the 360, but I had to be super intentional, like you were saying, about, okay, we're in person, we've got masks, which is simulating the experience that the student is having with the patient. So how can we use this moment in person with masks to talk about what it's like to communicate in this way? And then when we're on Zoom, how do we sort of recognize all the things that are kind of missing in that patient interaction and get more data in terms of facial expression and what's missing? So I found the combination, the more I could combine what was available to me, the better.
Yeah.
I know years ago when I was working at a community mental health agency, I had a client who was extremely anxious in confined spaces. She and I would go for a walk and do therapy. So I'm kind of wondering also for us to think a little outside the box, that even with the mask, and I recognize confidentiality issues certainly need to be considered, but consider having you know, classes in a little bit more of an open space maybe. And certainly things are kind of moving right now to a place where hopefully people are vaccinated. So we don't have to wear masks as much, but certainly, you know, I recognize the need to still protect yourself and others. But are there other creative ways of us doing the work that we're doing and not confining ourselves to what's traditionally seen as psychotherapy?
Well, thank you. I think we'll make that our final question as we approach 11:30 Eastern Time. There are many other questions, and one that I can respond to quickly is, as I said in my intro, we will have, if you're a member of the ACPE, there is a resource room that's being planned by the ACPE Curriculum Committee for certified educators to get together for an hour or so and just talk through these questions without a formal presentation. So really an opportunity for us to pick each other's brains, if you will. The date for that will be announced later. It'll be in the new year. But with that, I want to thank you, Arpana, Sarah, Marcus. Thank you so much for your participation today, and for all of you who joined in. We had over 100 people on the webinar today. So lots of great questions. Apologies we couldn't get to all of them, but please join us for the resource room in the new year. And thanks again to the ACPE Foundation for the funding for the research and for the dissemination of that for events like today. And especially a thanks to Transforming Chaplaincy. Thank you all.
Thanks, everybody.
Thank you. See ya.